one of the highest volume center, not in this country, also in this subcontinent. Please welcome Professor Fazilatul Nisa Malikan. She will talk on complication of femoral axis.
Right. So, friends and colleagues, it's indeed a great honor and privilege for me to be here today. Now, first of all, let's get this straight. We all, as interventional cardiologists, obviously want to have event and complication-free procedure for us. For us, as well as mainly for our patients, because when we do an event and complication-free procedure, only then can we give the best possible outcome for our patients. And I think it's a bit naive to say I'm a radialist or I'm a femoralist. You have to do what you have to do, and in many instances, maybe to get better support, or when it's a very complex case, you might have to use the radial route, and there's nothing wrong with it. The thing that is wrong with using a femoral route is when you get complications, or when you are not doing a good enough job, you're puncturing casually and you're leading your patient into complications. So the first rule for the matter should be that we should not have any complications. We should do the procedure so well that we do not have any complications. And for that, obviously, you have to choose your site where you can do it by angiographically, or you can do it by Doppler, but make sure that you're puncturing the common femoral artery, not below or not high up, and that should be the trick. Now, what else do you need to do? You need to, if your patient is hypertensive, you need to control your blood pressure before you do the puncture. And also after the procedure, you need to take proper care of your excess site, do proper hemostasis, and only then give. But still, even after the best possible measures, complications do happen. And if a complication, you should always keep in mind that there is a potential of complication. Even after my best possible effort, I might have a complication. That should always be in the mind. And the third most important thing is that if, God forbid, a complication should happen, do I have the necessary tools in my cath lab to tackle that complication? So these three components are very important to prevent complications. First, we do our best possible job. Next, we are always aware that there might be a complication, and to jump at the first awareness that there is a complication, and three, to have the necessary tools to tackle that complication. So with that, I would like to show you a case that happened quite a few years back. So this is a 63-year-old female patient who came to us with non-STEMI, and her ejection fraction was 42. And as you can see, there's nothing really complex about the case. She had a 90 to 95% LAD stenosis. She had an RCA dominant vessel with a 70 to 80% stenosis in the proximal part, and an 80 to 90% stenosis in the distal part. And we did the angioplasty, and the final result was acceptable. Now, after PCR, this patient was shifted to the post-cap ward, and 1 hour later, she started complaining of abdominal discomfort. She rapidly developed hypotension, followed by shock, and there was no pericardial effusion on the echo. ECG just showed sinus tachycardia, no other changes. Clinically, the patient was paper white, and we immediately shifted her to the cath lab. Now, in the cath lab, we could see that there was this central jet of blood going to the retroperitoneum from the external iliac artery. And the picture that was supposed to move is not moving, but at least you can get an idea of what was happening. So what we did in this patient is that we immediately took a covered stent, 7 by 8 millimeter covered stent, and we deployed our stent, and then the bleeding stopped. I'm sorry, the picture is not there. The last picture was about that the bleeding stops. The patient stabilized immediately, and she did well. So why did this happen? Well, obviously, femoral complications can happen, but maybe this was too high a puncture which happened. So femoral excess had complications overall. Starting from minor complications to major complications, the incidence is around 1.8 for diagnostic procedures, but it is higher for interventional procedures, around 4%, because in interventional procedures, we tend to use heparin and other like GP2B3 receptor blockers more. And it is true, radial access is associated with lower complications. It is more comfortable for the patient, and obviously it's a great to use, but sometimes you do need to use the femoral. Now, regarding the minor complications, you might end up with echinosis, bruising, or minor bleeding, or you might have a stable hematoma. Major complications would be if it's the hematoma requires transfusion, if there is retroperitoneal hemorrhage, there is pseudoaneurysm, arterial dissection, AV fistula, infection, vessel rupture, perforation, which happened to our patient, a vessel perforation, or limb ischemia. Now, when we start a procedure, we need to be aware that these patients are more at risk of developing vascular complications. So there are certain patient-related factors and certain procedure-related factors. Among the patient-related factors, female gender, low body weight, low BMI, elderly patient. On the other hand, also very obese patient, no peripheral vascular disease. And patients with CKD, yesterday it was being shown that even in CKD patients go for the radial route, because if you have a femoral complication, that would be catastrophic for your patient. So renal failure and patients with low platelet count that Hafiz just now alluded to. So these are patient-related factors that we must be aware of. Procedure-related factors would be like if you did angiogram 2 days back and then you again puncture the same femoral artery, there's more chance of hematoma. If you have high doses of anticoagulation or you have to give multiple doses because of a prolonged procedure, so check your ACT repeatedly. On the one hand, you do not want thrombosis. On the other hand, you do not want to risk bleeding. The use of thrombolytic agents, maybe the patient had a thrombolytic agent given just previously, and in our country we tend to use streptokinase. And the next day you're doing a pharmacoinvasive procedure. So in that case, give your heparin at the lowest possible dose and then step it up. Otherwise, bleedings can happen. Use of GP2B3 receptor blockers, larger arterial sheaths, especially 8 French catheters, concomitant arterial and venous sheath, prolonged indwelling sheath duration, prolonged procedural duration, and if you do multiple punctures. So all common sense things that we know. Now one thing that you, if it's a retroperitoneal bleed, which our patient had, one very easy way to detect it immediately is take the patient on the cath lab and do fluoroscopy. And if there is dye in your urinary bladder, usually the bladder should be round and oval shape. But if it is indented from one side, it means that there is retroperitoneal bleed, and that is pushing, the blood is pushing your bladder and making it look eccentric. So that is one sure way of understanding that there is retroperitoneal hemorrhage. The incidence of this is around 0.1%. Up to 0.5%, and it occurs, as I said, when there is high femoral puncture. Usually the patient goes into hypertension very rapidly. There may be back pain, groin pain, abdominal pain, and the patient might respond transiently to fluid load. Gray Turner signs, Cullen signs, these are real late signs. I mean, usually the patient collapses before these signs appear. So if there is a retroperitoneal bleed and the type of bleed that we had, like a jet of blood coming, then you need to be very, very quick, and you need to correct it as quickly as possible. So management, obviously you start giving the patient fluids, you arrange for blood and you give the blood transfusion. The patient has prolonged rest, and you need to maybe interrupt the anticoagulation, antiplatelet if required. And in severe cases like in our patient, we have to give a covered stent. In another case, what we did is, it was a small jet of blood coming. So what we did is we took a peripheral balloon, inflated it to low pressure and kept it for 10-15 minutes, and the bleeding sealed by itself. So if it's a very small bleed, maybe you can seal it with the balloon. But for large bleeds, you need to have the covered stent on your shelf so that you can apply it immediately. And very, very rarely, we have never ever done it in our experience, will you require surgical correction or evacuation. So with that, we also need to know where to puncture. So femoral puncture, it should be precisely at the site where the common femoral artery is. We cannot go above it, we should not go below it. And usually it is in the head of the femur, just in the middle part. Now, in most Western countries, they are using Doppler to do their puncture. In Bangladesh, we are doing it blindly. So when we do it blindly, we should at least take an angiographic guide. So palpate your anterior superior iliac and pubic tubercle, feel your femoral artery, do your puncture and take angiographic guidance if required. If it's a low stick puncture, complications could be a pseudoaneurysm, hematoma, or arteriovenous fistula. If it's a high stick puncture, when you puncture above the inferior epigastric artery, you might end up with retroperitoneal hemorrhage, and also with posterior punctures also there is an increased chance of retroperitoneal hemorrhage. And the thing is, the key to success is to detect, if God forbid such a complication happens, to detect it immediately and to treat it immediately. And for that you need teamwork, and for the entire team of National Heart Foundation, Hospital and Research Institute, I would like to say thank you for giving me this opportunity of presenting this.
Thank you very much, madam, for elaborating a very important issue. So the now floor is open. If you anybody have any comments or questions, please.
Absolutely. So doing a single one puncture would definitely lead to less chances of hematoma. But even if you do a double valve puncture, do it properly. Rather than like you're doing a half attempt of single wall puncture and you end up doing multiple punctures. Multiple punctures will lead to more chance of hematoma than an effective single wall, double wall puncture. And also after the procedure, do a proper job of hemostasis. In fact, they say for each French size, 5 minutes of hemostasis is required. So like say you use a 6 French catheter for your femoral. So at least you should give 13 minutes of hemostasis. And sometimes we usually maybe ask a junior or a technician to do the hemostasis, and maybe the hemostasis is not also being done in the proper site. So hemostasis is also very, once you remove the catheter, to do a proper job of stopping the bleeding is also equally important. Timing is also very, yes. Lower the blood pressure. Absolutely, you have to lower the blood pressure. Yes, so it has to be the common femoral artery where you puncture the vessel.
This is like a big problem now that we are using the devices from TAVR or from Impella. So, you know, Arnold Cito published the FOSS trial, the femoral access ultrasound guided study, where he showed that the ultrasound guided access is better than without ultrasound guided. But after Cito, not only we learned from that, we also started doing this with micropuncture. Before we use this TAVR cases with a large bore access, and then we do the pre-close, and then use this for a closer device. Do what goes, and then maybe an 8-inch angio takes care of it. This is very important to define at the very beginning of the case that we are okay in the access, because this is now a big problem. So we are now training our fellows more to be very perfect with the femoral access than we ever before.
Thank you.
Yes, madam. Thank you very much. Meet Jamal sir, I think he will join later. He just completed the live case session. May I now request Dr. Vinita Shah. She is the future leader of SKY. We noticed her 2018 in the TCT. She was delivering excellent lectures. So we noticed her now, and now we are enjoying her lecture live in Bangladesh. Welcome Dr. Vinita Shah, please.
Thank you for having me.
May I now request Dr. Sanjay? Could you please come to the dash? Vinita will talk on sudden hemodynamic collapse in PCI. What do I do?